dear doctors. So today I'm going to discuss about the Mrcp PACES consultation station, and I'm going to talk a bit about the lung transplant. Now this case, it can appear in your consultation station as well as in your respiratory station. So it is very important that you should know how to examine the patient and how to proceed with this case. So let's start our case. So first of all, we start with the history. This is a 52-year-old female. This has been referred by a respiratory physician for consideration of a lung transplantation. She has a past medical history of idiopathic pulmonary fibrosis and eczema. She has never smoked and does not drink alcohol. So despite previously maintaining an active lifestyle, she has an exercise tolerance of 20 meters limited by her dyspnea and has oxygen, home oxygen, and she's on home oxygen on 2 liters at baseline. Her respiratory symptoms have been rapidly progressing over the last 6 months. So lung transplantation is actually a treatment of choice for patients with advanced lung disease, which has progressed despite the management, medical or surgical. So lung transplantation, it actually offers improved quality of life and long-term survival for the patients. However, remember there is a strict selection criteria developed by the International Society of Heart and Lung Transplantation for patients who are eligible to undergo transplantation. Obviously, there is a limited number of organ donors and the nature of procedures with significant risk associated. So the selection criteria include if the patient has severe disease which is unresponsive or ineffective to medical therapy, if the patient risk of death from lung disease without transplantation is more than 50% within 2 years. Number 3, the likelihood of surviving at least 90 days after lung transplantation is more than 80%. And there should be absence of non-pulmonary medical comorbidities that are life-limiting in the first 5 years after transplantation, and there should be satisfactory psychosocial profile and support system. So as you can see, there are a lot of conditions where when the patient is eligible for lung transplantation. So patient should be sick enough, but on the other way should be fit enough to undergo this major surgery. The conditions of advanced lung disease that can be concerned for transplantation include COPD and idiopathic pulmonary fibrosis, interstitial lung disease, cystic fibrosis, pulmonary vascular disease, which is associated with the NYHA class 3 or 4. Now, there are contraindications to lung transplantation that are divided into absolute and relative. So, absolute contraindication include untreated, uncontrolled infection, whether it is pulmonary or non-pulmonary, active tuberculosis, malignancy in the last 2 years, significant extrapulmonary organ dysfunction, patient having coronary artery disease or any form of deformities, either chest wall or spine, if the patient is active smoker or the patient have drug or alcohol dependency. Some relative contraindications include age more than 65, BMI more than 30, severe or progressive malnutrition, severe osteoporosis, HIV infection, and untreated or active hepatitis B or hepatitis C infection. Now, I have mentioned we will ask about the exercise tolerance if we are considering any patient for lung transplantation. So, exercise tolerance, home oxygen requirement, rate of disease production, these are all key factors that are assessed when considering patient for lung transplantation. So this is about the history. Now we come to the oxygenation. So we see this patient. The patient has 2 liters of oxygen, was a nasal prong, BMI of 24. Hand examination did not reveal any stigmata of infective endocarditis. There were no signs of pale palmar-crisis or pale conjunctiva. She has moist mucous membrane, JVP is 3 centimeter. On examination of the chest, there was no chest deformities or kyphosis. There was no midline sternotomy scar. The apex beat was not displaced and the heart sounds were dual. On auscultation, they were fine crepitations bilaterally, more on the right compared to the left. And the examination of the abdomen was unremarkable with no evidence of pitting edema. So the thorough examination actually will provide clues of potentially undiagnosed comorbidities. General inspection will provide information on the patient's work of breathing and baseline function. Obviously, the continuous use of oxygen is an indicator of severity of a patient respiratory function. BMI is very important because having low BMI may indicate malnutrition, and BMI more than 30 kg per meter square is a relative contraindication for transplant. Now, I mentioned about hand examination because it can reveal the features of infective endocarditis, which definitely require treatment prior to consideration of transplantations. And we are all aware the infective endocarditis signs which we want to look for are ocular nodes, Janeway lesions, and splinter hemorrhages. So other signs on hand examination, we can see features of any iron deficiency like cholionicia or anemia, where we have palmar-crease pallor. So mucous membrane and the JVP, these are used to assess the patient fluid status. Elevated JVP more than 3 centimeters suggests fluid overload, and it could be suggestive of cardiac failure or renal failure. Chest and spinal deformities, they are relative contraindications for the lung transplantation. A sternotomy scar will suggest previous thoracic surgery, which is a relative contraindication. Bilateral crepitations, chest findings of bilateral cavity, these are consistent with idiopathic pulmonary fibrosis. So what investigations we like to do? So obviously prior to the transplantation, the patient underwent a range of pathology tests. We want to do full blood count, urea and electrolytes, liver function, coagulation profile, iron studies, hemoglobin A1C, random glucose, and BNP. So these are the basic tests which must do. Serology and tests for prior or current infection, these are also required. And she was also referred for cardiac function tests, respiratory function tests, assessment of bone health, and malignancy screening. So you can see that basic blood tests actually are performed to assess patient for anemia, any signs of active infection, renal function, liver function. Coagulation profile will be required prior to undergoing the surgical procedure. It can also identify bleeding and clotting disorders that are unknown to the patient because that may compromise transplantation. Hemoglobin A1C and glucose are tested to diagnose diabetes in patient without a history. For the patients with known diabetes, hemoglobin A1C obviously provide information of the glycemic control over the 3-month period. We also want to do the BNP. If the elevation of BNP more than 1000, it is suggestive of presence of congestive cardiac function. And infection screening in patient is crucial as the patient will require some immunosuppression post-transplantation. So infections that require screening, they include cytomegalovirus, Epstein-Barr virus, hepatitis B and C, HIV, herpes zoster virus, varicella zoster virus, and tuberculosis. So cardiac testing basically includes baseline ECG and echo, and for patient above the age of 45, consideration of cardiac catheterization for diagnosis of coronary artery disease. Respiratory function tests are performed to determine the degree of lung dysfunction and eligibility for transplantation. So it includes active spirometry and assessment of lung volumes, DLCO, 6-minute walk test, and ABGs. Systemic osteoporosis, severe, if it is severe, it is actually a contraindication for transplantation. So measurement of bone health is required through a DEXA scan. S- At the same time, the malignancy, it can shorten the patient life expectancy in early stages. In early stages, patient may be asymptomatic. So malignancy screening is required prior to the transplantation, which include colonoscopy within the last 10 years. If the patient are over the age of 50 years, female patient, we want to do the mammogram and pap smear in the last 12 months for women, and PSA for men. So management again will follow the same pattern. We'll talk about the immediate management, short term and long. So following successful lung transplantation, the patient was commenced on immunosuppressive therapy, including prednisolone, tacrolimus, and mycophenolate mofetil. So immunosuppression following any transplantation, it is required to prevent both acute and chronic graft rejection. So typically a combination of agents are used for maintenance immunosuppression, including glucocorticoids, which is prednisolone, calcineurin inhibitors, including cyclosporine or tacrolimus, and third is nucleotide blocking agents, in which we have azathioprine and mycophenolate mofetil. So you know that as time goes on from initial time of transplantation, the risk of rejection reduces. So the intensity of immunosuppression decreases over the first months. Glucocorticoids, where they are always included in ongoing immunosuppression for lung transplantation, and higher because higher pulse doses, it can be used during periods of acute rejection. We know that glucocorticoids got their own side effects if they're used for long term. So they can be increased risk of infection, hypertension, steroid-induced diabetes, mood changes, agitation, glaucoma, osteoporosis, easy bruising. So these are all side effects of prolonged glucocorticoids. Briefly, I'm going to talk about the calcineurin inhibitors. These include cyclosporine and tacrolimus. Now, the choice between the two is dependent on the transplant physician. However, tacrolimus is more commonly used now because it's an oral medication and it has a narrow therapeutic window. Tacrolimus level are closely monitored, and the recommended therapeutic dose varies at different stages and for different types of organ transplant. So one of the most common side effect of tacrolimus is renal dysfunction. What about the nucleotide blocking agents, where they include mycophenolate, mofetil, and azathioprine? And mycophenolate side effects includes myelosuppression, so regular monitoring of full blood count is required. Other side effects, they include GI discomfort, nausea, and diarrhea. So remember that in patients on long-term suppression, opportunistic bacterial infection can occur. So cotrimoxazole is prescribed for the prevention of pneumocystis jirovecii pneumonia, and the standard dosing is one double strength tablet daily 3 times a week. So double strength means 180 by 600 milligram. And patient who got renal impairment, they may require dosing adjustment. So cytomegalovirus infection is the second most common infection in the lung transplant. The first is obviously bacterial pneumonia. So antiviral prophylaxis is also prescribed to the patient with asymptomatic cytomegalovirus viremia to prevent its progression to any invasive disease. Cyclomegalovirus disease, it can present with fever, malaise, maybe patient have leukopenia or thrombocytopenia, and it can cytomegalovirus can also spread into tissues causing pneumonitis, enteritis, and hepatitis. So it is usually treated with oral valganciclovir or IV ganciclovir. And ongoing monitoring once to twice weekly levels of cytomegalovirus is used to monitor the treatment response. So briefly I'll talk about acute rejection. Acute rejection most likely to occur in the first 6 months and is a concern for transplantation. With many patients actually require treatment for acute rejection in the first 12 months after transplantation. The risk factors for acute rejection include HLA mismatching, younger age, and immunosuppressive regime which we have started. The clinical symptoms patient may present with dyspnea and cough. However, not all patients exhibit the symptoms. So, patient who got symptoms, they undergo basic investigations, including basic bloods, chest imaging, and spirometry to assess lung function. And then further investigation with bronchoscopy with lavage and biopsy may be required. So, some other causes of symptoms aside from acute rejection include infection and airway steroids. And treatment of acute rejection actually includes high dose glucocorticoids and ongoing monitoring. So, my dear doctors, that is all about the lung transplant. I tried to cover all the relevant points which is needed for this case and the questions which normally come up in the exam. Normally, with the lung transplant, it's a quite easy case once you have examined the patient and you can appreciate the thoracotomy scar, or if this bilateral lung transplant may have a clamshell scar. So once you do the investigations, remember examination. Remember to palpate the trachea to see whether any displacement of the trachea. That is very, very important, and that is a major clue that the patient has gone for the lung transplant. Normally, it will be deviated towards the um, it can be deviated or it can be central. Uh, so, uh, so the it's a quite easy case actually, but normally the questions the examiner will ask, they will ask about the indications of the lung transplant, contraindications of the lung transplant, what are the immunosuppression used, and may ask about the side effects of immunosuppression. Thank you very much, and I'll see you till my next presentation.